Okay. So a lot of references will talk about NICHD categories. I really don't test on this in my class. So if you are viewing this as a student of mine, you do not need to memorize it. I just want you to listen so that you know what people are saying when you're at clinical or if you read it somewhere. Um, when you go to labor and delivery, you will have to be familiar. If you work in that area, you will need to know these. But you'll get more familiar with that. So category one's normal. It's a baseline between 110 and 160. It's got moderate variability, and there are no late variable or prolonged decelerations. You can have earlies. Accels are great, but you don't need to have them. You need to have a baseline, the normal range, moderate variability, and none of the bad decels. Let's skip category two for now because that's complicated. Let's go to category three, abnormal. We know that this baby might have an acid base imbalance. They might have acidemia. They are hypoxic, and we are concerned about irreversible damage to that fetus. Category three is bad, 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 bad. Remember, I showed you absent variability? Absent variability with anything weird. So, absent variability with recurrent late decelerations, absent variability with recurrent variable decelerations, absent variability with bradycardia of at least 10 minutes, which is the definition of bradycardia, sinusoidal pattern for at least 20 minutes. Oh, wait, what's sinusoidal? She never said anything about that. A sinusoidal pattern kind of looks like this. Again, I think this one is simulated, but I have seen sinusoidal on rare occasions. It is really awful. See that there's really no variability, just this weird cyclical pattern. And a lot of times that is acidemia, but also associated with fetal blood loss. When you see placental abruption, uterine rupture, um, any condition where the fetus is losing blood and the mom is losing blood, you might see that pattern. So that is a category three. It requires immediate intervention. What do we do? Well, initially, what we do, I'm going to give you another mnemonic. It's called FLIP. Used to be called FLOP. I'll explain that too. We give a fluid bolus. Things aren't necessarily in this order, by the way, but fluid bolus of at least 500 milliliters to get more oxygen. We're sort of mimicking that extra blood volume that all pregnant women get to enhance oxygen delivery to the baby. The more circulating volume we have, the faster that baby's going to get the oxygen and nutrients it needs. Lateral positioning, left lateral, right lateral. Um, the book is always going to say left, but do whatever you need to do to get what you want. Sometimes you don't have to go all the way to hands and knees positioning to enhance blood flow through that placenta. I stands for informed provider. Now, if you're taking notes on paper or if you have a stylus of some kind, you can add a few things. There's a few other things we can do under I. You can do an internal exam to see if maybe what's going on is mom is ready to deliver. Um, you can do an internal electrode to better monitor that baby. So those are some things you can do. P is Pitocin off. If you have an abnormal strip, even if it's a bad category two, your pit goes off. Those are the four things. Now, they might be in different order. Sometimes you see variables. Your first instinct is to turn the patient. That's fine. Um, Fluid bolus might be the next thing you do. But that pit's going to have to go off if the baby's really not tolerating labor. The old mnemonic used to be FLOP, and the O was for oxygen. We used to give oxygen at 10 liters per minute with a tight face mask, a non rebreather. And then January 2022, ACOG did a review of a lot of different studies and found that oxygen really wasn't associated with any improved outcomes. And there was a potential for exposing women and their fetuses to free radicals at that high level of oxygen delivery. Every once in a while, if you have very minimal or absent variability, um, it can still, the literature still does support a brief intervention with oxygen, but generally speaking, we are getting away from the use of that. ATI has not caught up with that. Your textbook, which was published 2 years prior to this coming out, and NCLEX may still believe otherwise, so FYI. So this is why when I test on actions you're going to take, oxygen will not be an option, even if it is a select all that apply, because I'm teaching you current practice. But if you see it on an ATI assessment, you can select oxygen because people who wrote those questions have not updated them since the new practice change. Uterine activity, just a note about that. With an external monitor, we can measure frequency and duration. We cannot measure intensity. That little pressure sensitive button, depending on how much subcutaneous tissue the mom has, where you place it, what position she's laying in, may measure all different numbers at the peak of that contraction on the paper. So we can't rely on it for measuring intensity. For that, we use palpation. We feel at the fundus of the uterus during a contraction, peak of the contraction. If the uterus feels like the tip of your nose, go feel the tip of your nose right now. The contraction is mild. If it feels like your chin, feel your chin right now. That is moderate intensity. And if it feels like your forehead, that is strong intensity. And that is how we would measure intensity with palpation. If we have an IUPC in, we will get a number that reflects millimeters of mercury. There's all kinds of things you can do with that. I'm not going to get into them here because this is basic. Let's practice real simple and then we're done. Okay, so let's start with uterine activity. How far apart are these contractions? We start here, go to the beginning of the next one. It's about 1 3/4 or 1 2/3. A little close. And 1.5. Oh, this isn't a pattern I necessarily like. I like 2 to 3 minutes. So we've got 1.5 to 1.5 to 2 minutes apart. If I'm looking at a 10-minute period, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, I have 5 contractions. And I can kind of live with that, but I'm going to keep an eye on this. If this woman starts to hyperstim, I'm going to have to do stuff, and that's for a different day. So that is our contraction frequency. Let's look at the duration. We have 1, 2, 3, 4, 5, 6, 7 blocks. We're going to say that one's 70 seconds. Let's look for the shortest one. Let's not count every single one. 1, 2, 3, 4, 5, 6, 7. Yeah, they're about 70 seconds long. And down here we have some that 1, 2, 3, 4, 5, 6, 7. Yeah, about 70 seconds pretty consistently. Now you might be wondering, why are there 2 lines? Are they twins? No, this lighter shaded line here means that somebody put a pulse ox on mom to make sure that they were getting a fetal heart and a maternal heart. That is a very smart thing to do, especially when you have a low baseline. So that is some practice. Do you want more practice? Try this fun game. You can access it through the link. All right, guys, that is all I have.